كيف يا برو؟ الصورة واضحة.
أروى كيف؟ كويسين؟
الحمد لله الصورة واضحة والصوت
الصورة
واضح.
واضحة لكن الصوت واضح، لكن أعمل كيف عشان أجيب صورنا؟
إذا ظهر الصورة ظهرت.
الصورة ظاهرة لكن أنا ما ظاهرة لي في محل كده، مفروض ندوسه هسي فوق. أيوة ده محتصم كمان، والله مشاكل كثيرة الليلة.
كيف صباحين؟
أخبار هسي شايفني كويس؟
والله شايفك والله جميل.
شايف المنظر بورا؟
انت قاعد فين؟
أنا قاعد في زنجبار.
ما شاء الله ما شاء الله. في الفندق ما انا كنت قاعد فيه.
أي صحيح. لا جميل شديد.
جميلة. كيف امورك كويس؟
يط الدنيا كلها محتصم.
انا
مم.
صعب.
أحسن عشان الحكايات تسوى.
تمشي تستعدل ان شاء
بس
الله.
أرهقت بنتي.
والله انا ما ادريش يعني. والله ولا هبشتها.
أرهقتوها. لا هسي هي
لا
بس تتفرج. أنت خلاص امسك ناسك. ناس اللي
لا
بتاع
لا
20 ده
مشكلة. هاي
امسكهم
طبعا
بجمال كويس. وهو أنت
ما في
تمسك
مشكلة.
ناسك. نحن
هاي
عندنا
طبعا.
خطة التنمية اللي أروى دي.
اوكي تمام تمام.
تمشي في
الله
الأبحاث معانا.
ان شاء الله ان شاء الله. تمام تمام. اسمع.
هسي في ناس جوينينج.
عملت لي حاجة
أيوة
بس تحولها لي انا نمشي اعملها بقى بتاع الاجتماع ده.
صوتك ما واضح. الصورة واضحة لكن الصوت ما واضح. شكلك عامل ميوت.
كده واضح.
كده واضح صوت وصورة.
طيب لكن أنا صورتي عشان توضح أنا أعمل شنو؟ توضح عندي أنا.
طيب
The screen is on.
اوكي.
Now this is your screen.
ماي سكرين.
أيوة. بس كده واضح.
الصوت واضح والصورة واضحة.
الصورة واضحة. طيب نبدأ أحسن مش أحسن؟
أيوة.
Okay, welcome to this series of lectures on infectious and tropical diseases. We have been dealing with quite a lot of diseases which we call classical tropical diseases. Some of the what is called tropical is more prevalent in temperate climate as well as in the tropics. However, there is a international outcry to try and help African countries and tropical countries to eliminate some of the tropical diseases which are prevalent. A best example of an international effort which has paid dividends is malaria, because malaria is one of the killing diseases, one of the three major diseases, what we call the big ones, which are HIV, AIDS, and tuberculosis, as well as malaria. Malaria is very prevalent, and there is an estimate of 3.3 billion people around the world who are at risk living in an area of malaria. And we reckon that there is 250,000 people die of malaria annually, which is a large percentage. However, in the 90s, was a gloomy picture of malaria, but then the Global Fund, which I have highlighted last time, supported malaria control as well as HIV and tuberculosis. What happened between 2000 and 2015, there is a marked reduction of the incidence of malaria by 60%, which shows clearly that good effort will be in the line of elimination of a disease, and this is a good example. There are many countries which have eliminated malaria in that period, up to 2017 to 12. These are Algeria, the Arab country, in South America, Ecuador, Paraguay, and El Salvador. These are, and Argentina, Messi's house and Messi's home has also eliminated malaria. The Maldives Islands again eliminated malaria, and this is very important for Maldives because Maldives is a tourist attraction. And when you say that there is no malaria in that island, people will be invited, and encouraged to go to that island. So the effort of control has been based on two parameters. Parameter number one is to provide drugs, which artemisinin combined treatment, ACT, artemisinin combined therapy, which is a new drugs, okay, replacing the old drugs like chloroquine and the like. So providing these drugs for free from the Global Fund to African countries, that helped quite a lot of elimination of malaria. The second point is the work which has come from different parts of tropical Africa, that the impregnated bed nets are really helpful and really reduce the density and population density of mosquitoes. With these two being provided free for African countries, then the incidence of malaria has reduced a great deal. What is important to remember is that malaria as a common problem, both rural and urban. Like cities, you get malaria in rural areas like cities. Unlike other classical tropical disease like onchocerciasis, where it's mainly a rural disease. So malaria is widespread, and it mimics quite a lot of other diseases because basically malaria is a febrile illness with prostration, sweating, rigors, which can mimic other diseases like influenza, COVID-19, and jaundice with hepatitis A, These are common mimickers of malaria. So it's important to remember that the differential diagnosis of malaria is wide, but having experience in the particular country, then will give you a taste or an accent, and a taste or a six detector of the disease that it is malaria. However, I would like to emphasize that because it's common, it's overdiagnosed. And the overdiagnosis of malaria is, waste a lot of drugs, which are meant to be for treatment. But in severe malaria, which we are going to deal with, better give the drugs. And even if you are suspecting malaria, because severe malaria, as been defined by WHO, is a dangerous setting and dangerous disease, which has to be really taken seriously. Okay, so malaria is mal air, and that is the term given earlier before the discovery of mosquitoes being the cause of the vector of transmitting malaria. So mal air, meaning that there is polluted air around certain ponds, not knowing that these ponds are full of mosquito. But later on, Manson has clearly shown that the parasite is present in the mosquito. So it's female mosquito, and it's like all the other diseases. The female is the human biter because they need blood to grow their eggs. So it's that is something to remember. The male is more innocent and feeds on flowers and other things. You have to learn about this life cycle, about the habitat and habits of mosquito, and then we have to learn about the what is present within the body of what stage of the disease, because these are important. And as we're going to see, that some species of malaria will have a hypnocyte meaning a parasite which is kept dormant, or in hypnocyte will be kept dormant in the liver and then breaks at different times, even without being bitten again by mosquito. So the body can harbor the hypnocyte, they can develop into schizont, and then when they break, in the middle of nowhere, no mosquitoes around, then you get what we call recurrent malaria. And this is with certain species like Vivax, Plasmodium vivax, and Plasmodium ovale. So, what are the species now that are available? The number one severe is Falciparum malaria. So it is Plasmodium falciparum, which causes a lot of illnesses and a lot of deaths. And the fever of falciparum malaria is almost continuous. It doesn't have pattern, while the others have a pattern of paroxysm and then asymptomatic period and then paroxysm again. So falciparum malaria is the one which is, causes microvascular blockage of in the brain, giving you coma and affection of cognitive function, etc. And this is due to falciparum malaria collecting the cells, RBCs, adhering the cells to the walls of the microvilli. So we have falciparum malaria, one species, ovale, another species, vivax, third species, and then quartan malaria or malaria, falciparum malariae, which is other names quarter malaria. And these are the species around. There is one species, knowlesi, which is Plasmodium knowlesi, which is found in Southeast Asia. But for the time being, we don't. I don't want you to bother about it. Concentrate on these four species. So, what happens in the life cycle? The life cycle is sexual and asexual. The asexual is in humans, and the sexual part is in the mosquito. So, the infective part, which the mosquito injects in human, is called sporozoites. Sporozoites, and it's spelled Sporozoites, sporozoites. And these sporozoites are hidden or blocking the salivary gland of the mosquito. So when it pierces, when it inject itself or pierces the skin, uh, trying to liquidate the area by saliva. Then the saliva contains a lot of sporozoites. They go inside the blood, and there they go into the development. So what happens is, from the site of injection of infection, they go into the liver, and in the liver they grow to what we call schizont, schizont, schizont. And this schizont multiplies asexually into thousands of small uh, parasites, these merozoites. When the hepatocyte is full, it just bursts, leaving and discharging a lot of merozoites. The merozoites then seek in the blood, they seek the RBCs. They seek the RBCs, they get in the RBCs. And this is the time when there is symptomatology, when there is fever. At the time when the merozoites go and find their way inside the RBCs, this is the time of getting the fever. Okay. Some sporozoites, which are hidden in the liver, they develop these hypnozoites. These are the dormant one. They develop into a latent schizont, and they can be there in the liver for years. And this is only for Vivax and Oval. So they can be there for years, and once the immunity is broken down, or you are tired, or in malnutrition or pregnancy or whatever, where immunity is not that intact, then it breaks up the schizons and release the merozoites just like it's received it today. So they get another fever. So recurrence of fever of malaria is often talked about wrongly, because in falciparum malaria we don't have recurrence, we have reinfection. But with Vivax and Ovale, we can have recurrence because some of the sporozoites can hide themselves as hypnozoites in the liver and develop as schizonts and be dormant for years to break sometime in the future and give you fever again. This is not happening with falciparum. I keep bringing back the falciparum because, as far as we are concerned, in Africa, in Sudan, the major problem is with falciparum malaria. So, what will happen is that some of the merozoites which has gone into the RBCs, they change themselves and develop into a sexual ova, or into a gametocyte, what we call gametocyte. So the gametocyte differentiate into male and female, and then they join and they contain themselves as a zygote. This is very important part of the cycle, because this is what continues the malaria to go on. If you don't have gametocytes, if the merozoites which are released do not develop as gametocytes, then you will never have a continuation of malaria. So these gametocytes will hide themselves into the wall of the intestine as a zygote, and they go on to develop okainete, okainete, and this insists itself in the gut wall, and it becomes, after insisting, it becomes oocyst. O is OOCCYST, cyst, oocyst. Okay, and then this oocyst contains all the developed sporozoites, and from the gut they go to the salivary gland and break into sporozoites, which can be injected, and the cycle starts again. So the two parts of the cycle, the cycle is the one from sporozoites to the schizont, and from the schizont we get again rupture into merozoites. The merozoites goes to the RBCs. Some of the merozoites will develop into sexual gametocytes, and then they go into oocyst, and then they go into salivary, being sporozoites, and sporozoites will go. So that's one line. And the other line is some of the sporozoites will go and hide themselves in the liver. That is in two species, vivax and ovale. Okay, what is the incubation period? The incubation period is important to remember, because if you have somebody who is visiting a tropical country and who goes, by airplane, landing in, say, London or Liverpool, then the second day or third day he gets a fever. People will just jump to say this is malaria. It has to be remembered that for the shortest, which is falciparum, you need 7 to 14 days. So if it is before the first week, in the first week or before the 7 days, it is unlikely to be malaria. And if it is after the 14 days, if falciparum, that again is maybe it's malaria. So you take the range of 7 to 14. However, with other malaria like vivax and ovale, this can go on for months. Okay, they can go for up to 1 month or 2 months, the incubation period. So if you have a fever later in the second month, you say, well, I've been in the tropics, but that's about 2 months ago. So it can't be malaria. No, it can, if it is another species of mosquito, another species of the parasite. So the parasite is will continue in the population, and the intensity of malaria depends on one, the mosquito, its breeding sites, its longevity, how long it lives, then on population density of the flies, and on the ambient temperature, because certain temperature will favor the growth of the mosquitoes, and then the biting habits of the mosquito. And the other part of the human is the host immune response. So the first part is the population of the mosquito. Too much population, they are very active, the temperature is good for their egg formation, and then the population density is, having a biting habits and biting abilities. This is again measured, okay, and what we call inoculation rate. The inoculation rate is the biting. What we call is an epidemiological index, which is called inoculation index or inoculation rate, giving you that the bite is, so how many each mosquito will do this, like 5, 6 biting, and the more they do, the more they transfer sporozoites of malaria. So these are the factors, because we're going to talk about, people who are showing vaccine positive but are asymptomatic. They are asymptomatic completely. They have fever. We can't label them as malaria because they don't complain, but they still have parasites within the body. The most important part, if parasites are these parasites are gametocytes. Okay, some of them are ring form. What we see in the Gims stain is ring form of the parasite, but gametocyte can also be seen, and gametocyte, as we already indicated, that it continues the cycle. If you don't have gametocytes, then the cycle will be cut off. And then the importance of drugs which will kill the gametocyte as well as the form of the malaria, then this is what we rely on to interrupt transmission. So it's this is the dynamic process of developing malaria, continuing developing malaria. So you need an immune response, and this immune response is so variable. Okay, so we call people whom we call non-immune are those who joined or came to the country without having been exposed to the antigen of malaria. But in tropical countries, neonates, even through the placenta, children are sensitized against malaria from neonatal period, and the child will be protected for 6 months. For 6 months after delivery. After the 6 months, up to 5 years, this is the critical period whereby the child can have very severe malaria. That is, if no immunity. So we can divide areas of malaria into 2 areas: the stable malaria region and the unstable malaria region. What is a stable? Stable malaria region is there is intense transmission. Intense transmission. Transmission is intense and all the year round. All the year round. It's not like where you have rainy season, when you have seasonal transmission. So the stable malaria is all the year round. So what will happen? What will happen? The adults will have immunity. Okay, the children and those who are weak will have the infection, and those are the young children, particularly 5 and less, and the pregnant ladies. These are the one in stable malaria, and the stable malaria is all the year round, then providing immunity to the population. So the unstable is when the malaria occurs in a season, like in Sudan. It's usually occurring during the rainy season, and you see in the rainy season, even in the capital, you can see a lot of ponds, a lot of frogs which are crying all night, and these are very important places for breeding of mosquitoes. So here it comes at all ages, because people will have less immunity. They are not exposed all the year round, so they have less immunity. So all people, adults and children, can get malaria, but the transmission is low, unlike the intense transmission of the stable malaria. Okay, as far as human beings are concerned, we have two types of immunity. What we call innate immunity, INNATE. Yes, I'm sure you remember it. This is built-in immunity for different reasons. The best example which I can quote is certain genetic variants of RBCs. Certain genetic variants of RBCs have the ability to resist malaria. These are sickle cells. These are glucose 6-phosphate dehydrogenase deficient RBCs. These are thalassemia trait cells and ovalocytes. These are, deformed cells, but they have the ability to resist malaria. Okay, so this is what we call innate immunity, genetic variants of the RBCs. There is an antigen, or there is a receptor in the RBCs which has to be there for certain species to bind in RBCs. Otherwise, the plasmodium will not get into the cells. And this is called Duffy antigen. DUFFY, Duffy antigen. Okay, these are the receptors for the merozoites. You remember, the merozoites is cut from the hepatocyte, needs to go into the RBCs. And if in vivax, the merozoites go in and the RBCs have no Duffy particle or have no Duffy receptors, they don't go in and they die. So this is why in certain African countries where there is absence of this receptor, Duffy receptor, vivax is not common. The vivax is not common. Okay, the acquired immunity, that is the innate, which is within us. And then the acquired immunity is repeated exposure. When you have repeated exposure for anything, you may have an immunity develop. And even when you talk about mosquitoes, certain people are bitten more often by mosquitoes and they feed. Others don't, even if they are living in the same house, same area. Okay, so there is more to learn about habits of mosquito, about the response of human to the presence of mosquito. So these are, but as far as we know, in the unstable area, all ages can be affected because they are not exposed commonly. In the stable malaria, where there is intense transmission all the year round, then that is the case where you get immunity and the disease will be restricted, almost not exclusively, but restricted to children and pregnant ladies. And these are the two groups of people we really get scared when they have malaria. For this, the deaths and the complication of malaria is often in these two groups. Okay, the other associates of malaria is, for instance, HIV. This is again is a good example of when the immunity is broken. What happens with HIV? The malaria increases the viral load of HIV. It increases the viral load of HIV. On the other hand, HIV increases the incidence and severity of malaria. And if a pregnant lady who has HIV and malaria, then the outcome is not good. The baby will maybe stillbirth, low birth weight, and with neonatal malaria with no protection. So HIV interact negatively. Malaria with HIV interact. Both diseases, they go into an interaction which is not favorable to a human being. Okay, having set the cycle, what are the factors which increase the likelihood of malaria, decrease the pathology, make it more severe. But what are the clinical features? Let us go back to the clinical features. Basically, malaria is a febrile illness. Malaria is a febrile illness. Okay, true that the fever may be variable, but essentially it's a febrile illness. Okay, what happens if I don't treat malaria? If it's falciparum malaria, it's usually fatal, especially in children. So you have to treat malaria as soon as possible, especially when it's complicated by cerebral complications. Okay, in cases of Vivax or Ovali, if you don't treat malaria, it becomes like a chronic malaria, which is, the parasite is the patient may feel prostration, they might feel ill, and they develop anemia. But falciparum malaria, in other words, is the one which gives the classical symptoms of malaria. Okay, and in some words, this is called malignant malaria. The others, like Ovali, quartum malaria or malaria, and Vivax, are called benign malaria. They don't give a lot of fevers. They are sort of go chronic. But the falciparum malaria is the one which is serious. And falciparum malaria don't have a hypnosite. So once you treat it, you finish it. Like other Vivax and Ovali, if you treat it and you don't treat the hypnosite or the latent schism, then the malaria comes back. But for falciparum malaria, once you treat it, it goes. But the acute phase of this is serious. The acute phase of this is serious. Why? What are the other features before we see the reason? What are the other features of falciparum of malaria? It goes into phases. Okay, the acute phase, the hot stage, and then the sweating stage. Okay, if you get malaria parasite in good numbers, then you get acute initial cold برد تحس بالبرد كده ولخبطوني بالبطانية. Okay, and then after this you get shivering, rigors. Okay, and you actually shiver, you actually shakes with this rigor. يقول لك الرجفة بتاعت الملاريا. Okay, so that is stage 1 and continues for some time. Then it goes into a hot stage. The fever comes, and the fever may go up to 40 degrees or more, 40 degrees or more, and then the patient becomes restless and excitable, and start, maybe abdominal pain, diarrhea, and vomiting, and he becomes so weak. And then the third stage is sweating stage. The sweating stage, the temperature goes down, and then the patient may feel sleepy and may go to sleep. There are always some associated symptoms. One of them is headache. I have never seen a case of malaria without headache. So headache is a constant feature. Okay, headache is a constant feature. And then people would like to call abdominal malaria, but vomiting, abdominal pain, and diarrhea is so common with malaria. I don't think there is a reason to call it a separate abdominal malaria. Okay, so they can have cough, vomiting, and hypoglycemia. Hypoglycemia is one of the problems with malaria, because then if you give quinine, hypoglycemia may be exacerbated and increase the coma. Okay, malaria don't give rash and don't give pharyngitis, and don't give lymphadenopathy. Why I'm saying this? Because we have common fatality in children with malaria, and these are the rashes, is commonly seen in children with chickenpox, measles, etc. Pharyngitis with diphtheria and others, and tonsillitis, okay? And rash, again, is this lymph nodes enlargement. Again, they are not seen in malaria. So we don't have pharyngitis, we don't have lymphadenopathy, and we don't have a rash with malaria. So if you have a child with any of these presenting, then you have to think of something else, because there are many reasons of fever. And when we come to the differential diagnosis, we can count more than 10 or 15. Any case of fever that resemble malaria. And then this is acute phase, okay? Acute phase or acute malaria. Then we have the chronic malaria. Chronic malaria is low-level parasitemia, okay? Either recurrent attacks of anemia, okay? Hepatosplenomegaly, weight loss, but these may resolve by themselves, okay? So there is general weakness, recurrent attacks of anemias, hepatosplenomegaly, and again these are, and the parasite is there, okay? So it's what people like with chronic malaria, and this is more often in vivax and ovary. And then there is a distinct syndrome of chronic malaria. This is hyperreactive malaria. Hyperreactive malaria. Basically, it's huge spleen. Basically, it's huge. We used to call it tropical splenomegaly, but now people would not like to see that name. I don't know why. But tropical splenomegaly. So what happens with tropical splenomegaly or hyperreactive splenomegaly? Hyperreactive malarial splenomegaly. First, this huge spleen can be misdiagnosed as something else, like myeloid leukemia, myeloproliferative disorders, even Kala-Azar, especially with fever. That's another differential diagnosis of malaria. You can get huge spleen with portal hypertension, particularly schistosomiasis. So these are the causes of huge spleen, okay? So huge spleen have a symptomatology of its own. Any huge spleen will lead to pancytopenia, will lead to low hemoglobin, low neutrophils, and low platelets. This is what we call pancytopenia of hypersplenism or pancytopenia. Okay, hyperreactive splenomegaly. Okay, there is no lymph nodes. That is important to differentiate it from myeloproliferative disorders or lymphoid disease, Hodgkin disease. Okay, so what are the features of this hyperreactive spleen? Number one is very big spleen. That's number one. It goes without saying. It gives anemia, even out of proportion to this just a large spleen. Because a large spleen will give anemia, but here it is more than what we expect from hypersplenism. Okay, they can get bacterial infection. Okay, then importantly, they are hyperglobulinemia. Hyperglobulinemia, and this is mainly IgM. So if you go send the liver function test for albumin, it may be normal, right? But the globulins will be very high. That is usually the ratio between albumin and globulin. What we use to reverse albumin to globulin. Globulin is usually low, but the reverse when you have diseases like Kala-Azar, So it's very high globulinemia. If you have tropical splenomegaly, like what we are talking about now, you can have a huge amount of globulins, particularly IgM. This is again classified as chronic malaria. And another form, which again is linked to chronic malaria, is what we call Burkitt's lymphoma. Burkitt's, Burkitt's, Burkitt's lymphoma. And this is Burkitt. Burkitt has many syndromes, but this is a syndrome whereby students get, not students, the children will get lymph nodes, mainly in up here, okay, in a belt of malaria. And they think that Burkitt's lymphoma is caused by a virus called Epstein-Barr virus. Epstein, capital E, P-S-T-E-I-N dash Barr, B-A-R-R virus. This is Epstein-Barr virus, which is incriminated in the development of Burkitt's, but you need to have a malaria infection on chronic basis. So Burkitt's lymphoma is related to a belt, usually it was described in Uganda, and I had the pleasure of meeting Epstein in Bristol. He's a virologist. Okay, he's one of the leading virologists at the time in Bristol. So Burkitt's lymphoma is also related to chronic malaria. The last one is nephrotic syndrome. Nephrotic syndrome can occur with malaria, okay, and people have found that there is an malaria antigen in the glomeruli. Okay, unfortunately, if you treat malaria, the nephrotic syndrome will not go. The nephrotic syndrome will not go. So the chronic malaria is, you can have chronic malaria with parasitemia, with vague symptoms. You can have chronic malaria, with tropical splenomegaly, hypersplenism, related chronic malaria to Burkitt's lymphoma, and chronic malaria can relate to nephrotic syndrome when you have an antigen in the glomeruli, and it's thought due to malaria, Plasmodium malariae. Okay. The two groups which we really fear to have malaria are the children and the pregnancy. In pregnancy, usually in a stable transmission zone, which goes all over the year, pregnant ladies and children are the ones who are more exposed to malaria, and they are the ones who have major complications. Anemia is one, and anemia is out of proportion to the pregnancy. They can have stillborn, they can have a low birth weight, maternal mortality and morbidity, because mother can succumb to malaria. Now, this we are talking about severe malaria, not the casual malaria with no parasite. It's a severe malaria. If it attacks pregnant ladies, then that is the outcome may not be favorable. This is why you do not hold any treatment from pregnant ladies. Whatever that saves or treats the malaria will do it. Okay, so it's important. Anemia can occur, as I said, hypoglycemia can occur, and other complications is fetal distress and premature labor, stillbirth, and pulmonary edema can occur. So this leads severe malaria in pregnancy can, in a nutshell, can lead to fetal death, either stillborn, low birth weight, okay, or premature labor, and then this is becomes serious and children may succumb. Okay, so these are, the dangers. What makes falciparum malaria more malignant than the other malaria? They have the capability, Plasmodium falciparum has the capability of making the cells cytoadherent to the walls of the microvilli, the walls of microvilli. So what will happen if you have small venules or arterioles where it becomes blocked by RBCs? So they adhere to the wall, and then more cells will come, and they make a block, and even our normal RBCs, which do not contain the merozoites, can be attached to the abnormal cells of the merozoite containing RBCs and make a rosette. A rosette is a collection of cells of different types called the result, and the rosette will act like a bolus or a thrombus, and then this blocks the microvilli. And this is one of the causes of coma, and this is one of the causes of death. And the work which has come from Malawi by a good researcher who worked in Sudan and learned tropical medicine in Sudan is Taylor. Dr. Taylor, she's a female, has gone to Malawi after Sudan, and she did a lot of work, especially post-mortem work, in children with death of acute malaria or cerebral malaria. I found that the major problem is multiple arterioles being blocked by these cytoadherent cells to the arterioles. So this is one of why falciparum malaria is called the malignant type of malaria. Secondly, it is usually the one which has parasite, hyperparasitemia, okay? And the level of parasites is taken by the WHO as a major differentiation between severity of malaria. So they can go up to 100,000 per microliter, and this is very dangerous, and it can only occur with falciparum malaria. This is why this is called malignant, and because it can go in the brain, it can cause very severe symptoms, it can cause complications, and it can cause coma and death. The other contributing factors is hypoglycemia. Hypoglycemia is often seen with malaria, with treatment or without treatment. With treatment, the treatment which causes hypoglycemia is quinine. Quinine is a cause of hypoglycemia thought to have hyperinsulin secretion. Okay, but malaria by itself is also can be associated with hypoglycemia, more so with quinine. The problem is, hypoglycemia can cause drowsiness, coma, and the malaria can cause this. And if you are not aware, or you don't put it in mind, you can miss the hypoglycemia, and damage can occur more from the hypoglycemia than the malaria. So always, this is the physical signs of the note, which should be noted by the physician even without symptoms. We don't expect the classical symptoms of hypoglycemia because the patient is already ill, sweating, shivering, which are all signs of hypoglycemia. So it's important to think about it. Okay, so that is more or less the clinical features of malaria in the different forms, and inshallah in the next lecture we have to divide what are the criteria of severe malaria, okay? What are the symptoms and signs and the investigation of severe malaria? Why do you want to do this? Because this is associated with high mortality, okay? And this is well categorized by the WHO. Secondly, it will not only tell the prognosis, but it will urge the system to work hard. It will urge the hospitals, the doctors to act quickly. If you have anyone who is suspected to be having severe malaria, then this is a top emergency. And treatment will be started even before diagnosis. So, to conclude, I would like to say, how is it diagnosed? Okay, the clinical picture we have said, the history we have said, okay, this will add to the diagnosis or differential diagnosis. But the differential diagnosis, as we said, is other fevers, the influenza viral fevers, COVID, influenza, typhoid fever is another example, Kala-Azar in areas of Kala-Azar fever, even malignant fevers can occur, pulmonary diseases can also occur, urinary tract infection can cause fevers, but these are, well differentiated by the symptoms of the patients and then easily diagnosed by a blood test or by urine test or chest x-ray or taking a sputum. So that is differential. The hallmark of diagnosis is the ring form in a Giemsa stain. The blood film is taken from here, thick blood film. We take 3 blood slides at different times, and it does not need to be during fever because there is concept. Usually, they say you have to take it when the fever is up. This is not correct. So that whatever you can, take 3 different at different times and stain it with Giemsa and then look for the rings, okay, within the RBCs. You need some expertise, okay, because platelets can mimic, fragmented structures can mimic RBCs, but usually it is in good hands. It's very easy to see, but it needs careful looking. So Giemsa stain. Okay, there is a rapid diagnostic test, RDT. This is ICT test, which can give an indication, but it's not very sensitive. Nowadays we have histidine protein in the plasmodium, which can be detected by certain antibodies, by PCR, okay, polymerase chain reaction. This is highly sensitive, and not only it's for diagnosis, but it can also give a prognostic indication. So that the diagnosis is dependent very much on the blood film. You do 3 blood films at different times, not necessarily during the fever. Number 2, ICT, a rapid diagnostic test, and then the PCR, the polymerase histidine protein rich histidine antibodies are being detected by antibodies through the PCR. This is very sensitive, but obviously it's very expensive and it needs a lot of expertise. So with that, I think we will conclude today's lecture, and the summary will be that malaria is very common. It's still common, although there is a reduction in the last 10 years or so, down to 40% of what it used to be in the 90s, but there's still a lot of work need to be done. The severe malaria is a cause of death still. About 250,000 people die every year. This mosquito, female mosquito is the vector. And whatever effort we take to separate human beings from the mosquito, then that will reduce malaria. Kill the mosquito here, we prevent the mosquito to come in contact with the people during the night through impregnated net or whatever, then that is that will reduce the incidence of malaria. So in Africa, pregnant ladies very advised to use impregnated nets, okay, to prevent the bite. And the bite is usually during the night, as you know. It's a night biter, okay. So during the day is no danger, but during the night. So if you protect yourself during the night by impregnated bed net, then the net not only mechanically prevent the entrance of the mosquito, but because it has an insecticide impregnated in the material itself, when it catches or sits or land on the cloth or the net, then it dies because of the thing. Apart from the mechanical prevention, there is a chemical prevention of mechanical death of the mosquito. Obviously, because I'm sure people had it in the community medicine that there is the how to dry the waters, how to use oil just to prevent the larvae of the mosquitoes to breed, You can spray the houses, You can spray the fogging, um, fogging insecticide that is within the house. The fogging it goes within the house in the closed area, but then spraying, it can be from house to house by machines, by men, or you can spray through the aeroplanes. So whatever effort you do to kill or to reduce the population of the mosquitoes, to prevent the mosquito from getting in contact with humans, all right, and then early treatment. And this is what we are going to do next lecture. We're going to talk about severe malaria, what are the signs of severe malaria, how to treat severe malaria, and then we talk about medical treatment of malaria. So with that, I think we finished today's lecture, which is 60 minutes, and looking forward to seeing you next Sunday. Okay, thank you, bye.